We have talked about refractive surgery, and we have talked about cataract surgery, but what about refractive lens exchange? In this episode of OCuTALK, ophthalmologist Arjan Hura discusses all things RLE, including who makes a good candidate, how the procedure works, and what patients should expect post-procedure. Hello, and welcome to OCuTALK. Today, we're going to be having a conversation with ophthalmologist Arjan Hura. Hello, doctor. How are you today?
Hey, I'm doing great. Thanks for having me on again. I appreciate it.
Yes, thank you for coming back. For those of our viewers who did not see your last video, would you please tell us a little bit about yourself and your background?
Yeah, absolutely. So I am a refractive and cataract surgeon. I practice at the Arjan Hura Vision Institute in Los Angeles, California, and I specialize in refractive surgery, which is a subspecialty within ophthalmology focused on vision correction, essentially getting people out of glasses and contacts and helping them see better, whether that's in the form of PRK, LASIK, SMILE, EVO ICL, cataract surgery, or what I think we're going to discuss and focus on today, refractive lens exchange. So I grew up in Ohio. I did all my medical training there, including medical school and residency in Cincinnati. And then I did a private practice refractive surgery fellowship in Cleveland, and then ultimately moved to Los Angeles, which is where I am now.
Well, that sounds pretty perfect because today we were hoping you could talk to us about refractive lens exchange. What exactly is that?
Sure. And maybe for the sake of context and completeness, we had previously discussed PRK, LASIK, SMILE, and EVO ICL surgery. So if anyone's interested in that, I encourage them to go back to that video to learn about those topics that we'll reference here today. PRK, LASIK, SMILE, those are forms of laser vision correction done at the level of the cornea. EVO ICL is a lens-based procedure that adds a micro implant to the front part of the eye without the need to remove or reshape any of the eye's natural eye anatomy. And refractive lens exchange in cataract surgery, they involve the removal of the eye's natural lens and replacing it with a lens implant to improve vision. And it might be easiest to explain RLE or refractive lens exchange by kind of first broadly examining how the eye works in general. So light from around the world enters the eye by first passing through the cornea. That's the clear watch glass portion of the front of the eye. Light then passes through the front part of the eye into the lens. And much like a camera has a lens that's used to focus an image on the film, which is used to develop a photo, the eye also has a natural lens that focuses images onto the retina, which is the eye's neural tissue version of camera film. The retina then converts that light into electrical signals that the optic nerve then transmits to the back of the brain, and that is how we perceive vision in the world around us. And the eye actually has two focusing elements, the cornea, the clear part of the eye, and then the lens that's inside the eye itself. If someone's born with a prescription, let's say they're nearsighted, which means they can naturally see up close without glasses or contacts, but the distance vision is blurry, well, that can be corrected by glasses or contacts. Glasses and contacts will help properly focus light on the retina, and then the person can see better. PRK, LASIK, SMILE, they can also correct for that prescription by reshaping the cornea to more accurately focus light on the retina, which gets rid of the need for glasses or contact lenses. And PRK, LASIK, and SMILE can also correct certain degrees of astigmatism, and PRK and LASIK can also correct certain prescriptions of farsightedness as well. When we're young and in the first 40 to 50 years of life, low to moderate levels of farsightedness, a plus prescription essentially, that typically doesn't require any glasses, contacts, or surgery to correct because the lens that's naturally in the eye is able to what's called accommodate. It can pull through the farsighted prescription, effectively neutralizing it. The lens can only accommodate in one direction, though, which is why someone who is young and naturally nearsighted or myopic, although they can accommodate, the accommodation is optically moving in the same direction as their nearsightedness, so it doesn't cancel out or reverse their nearsightedness. I'm obviously speaking in general terms, so what I'm saying is not necessarily perfectly accurate in terms of anatomy and optics, but it just gives a general sense of how an eye functions and how different prescriptions kind of affect our ability to see. So if you're young, let's say, and you have a mild amount of farsightedness, you likely won't need glasses or contact lenses to see well. You won't need any surgery to see well either. And you likely won't need any correction until you hit your mid to late 40s or even early 50s. At that point, something called presbyopia sets in, which is the age-related loss of near vision. That's when the lens in our eye that we're born with, which is normally crystal clear and flexible, the flexible nature is what allows for accommodation. You know, you can look far away and then spontaneously look at something up close and see it in focus. That flexibility starts to slowly, over about 4 decades, disappear, and the lens loses its elasticity, and that accommodative capacity goes down. And that's why people in their 40s and 50s, they have to start holding the phone further and further out from their face, or they make the font bigger, or they put on reading glasses. People who have sort of the opposite issue, which is they were born with nearsightedness, again, the ability to naturally see up close, well, if they've never had their vision corrected with PRK or LASIK or SMILE, if they've just used glasses or contacts, when they hit their 40s and 50s, they're still able to read just fine without any correction. But when they put on glasses or contacts to see far away, they will no longer be able to see up close. And that's when people either wear contact lenses and then put readers over their eyes, or they start using a pair of bifocals or progressive glasses. The way to kind of get around that is something called monovision, which is where one eye is set for distance and one eye is slightly set for up close. Not everyone's brain can tolerate that discrepancy between the two eyes, but some people are naturally born with monovision or they've tolerated it for years or decades in glasses or contacts. If that's the case, they can often get through presbyopia, that presbyopic age, 40s to 50s, without reading glasses because one eye is still able to see up close a little bit. And that can be done with glasses. It can be done with contact lenses. It can be done with laser correction, EVO ICL, or even RLE or cataract surgery. And then sort of the final stage of lens development is when someone enters their 60s and 70s, or maybe even later in life, that naturally clear lens that's stiffened up in the 40s and 50s, it starts to become kind of cloudy and opaque. And that's what we call a cataract. So the clear and flexible lens is now translucent or opaque and inflexible. So light's entering that eye, it's getting through the cornea and hitting the lens, but it's having a hard time going through the cataract to reach the retina. And it doesn't matter whether you do glasses or contact lenses, focusing the light, it can't get through that opacity. And so typically at that point in life, that's when we recommend having cataract surgery. That opaque and inflexible cataract's removed, and then it's replaced with a lens implant to help the patient see better. So I know I've talked a lot and we discussed myopia, farsightedness, astigmatism, accommodation, PRK, LASIK, SMILE, EVO ICL, cataract surgery, but I didn't really answer your question and discuss RLE that much yet. And that's because I just wanted to provide context so everyone can understand how the eye changes throughout life. And it's going to be important to talk about what's the right time window for a patient to most optimally have RLE. So RLE is refractive lens exchange. It's referred to by various names, so sometimes it's confusing. If you go on the internet and look it up, you'll see people call it clear lens replacement, custom lens replacement, clear lens exchange, lens replacement surgery. These are all referring to the same thing. RLE is simply the removal of the natural lens from the eye before that lens has become a cataract. That's it. The surgery is the exact same as cataract surgery in terms of the general steps of the procedure, the types of lens implants that are used. It's just typically performed earlier in life than when we would normally do cataract surgery. So most people who get RLE, they're in their 40s and 50s. Presbyopia has kicked in. They're having a hard time seeing up close. Maybe they need glasses for all distances or maybe multiple pairs of glasses, and they want to see better without corrective lens. Sometimes a younger patient may have a very extreme prescription that may not make them a candidate for, let's say, PRK, LASIK, or SMILE, and they may benefit from RLE at a younger age, but the average RLE patient is in their 40s and 50s.
So, who makes an ideal patient for this procedure?
Yeah, great question. So, I kind of view patient candidacy for RLE in two parts. The first is what makes a patient a good candidate in terms of their eye anatomy. And then the second, and maybe just as important, is what makes a patient a good candidate in terms of their expectations and the actual results that they can achieve. A patient who's typically a good candidate in terms of eye anatomy, that's someone who has mild to moderate amounts of farsightedness and who is typically already presbyopic. They've gone their whole life without glasses, and now all of a sudden they're in their 40s and their 50s. They're having to use reading glasses, and it really bothers them. Young patients who have very high levels of farsightedness who are not good LASIK candidates, they may also be good candidates if, again, they just can't stand their glasses and contacts. But I typically will not recommend RLE to someone who's very nearsighted because nearsighted patients in their 40 or their first 40 or 50 years of life, they typically have not yet had what's called a posterior vitreous detachment. So just to quickly go back to eye anatomy, when we're born, the back part of our eye in front of the retina is filled with a gelatinous-like substance called the vitreous. And that vitreous is firmly adherent to the retina. And typically, as we get older into our 60s, 70s, and 80s, the vitreous naturally liquefies and then tugs off the retina. When this happens, there's no more traction from the vitreous on the retina, although during that process of detachment, there's a risk that it could cause a retinal tear in the process. And people who are very nearsighted, they often have eyeballs that are longer than average in length. And that puts their retina naturally more on stretch, so to speak. And areas of their peripheral retina can sometimes already be weaker or have holes in them. And so the act of the vitreous tugging or coming off the retina may make them more predisposed to developing a retinal tear. And we know from the peer-reviewed literature that the active refractive lens exchange, as gentle or as efficient of a surgery as it may cause some mild jostling of the vitreous, typically inconsequential for someone who is farsighted or someone who just has a very mild prescription. But for someone who is very nearsighted and has a long eyeball, and maybe they have some pre-existing weak areas to their retina, this jostling of the vitreous can put traction on the retina and it can lead to a retinal tear or detachment. So while I'm fine recommending refractive lens exchange to farsighted patients or people with mild prescriptions, I typically won't recommend it to those very high nearsighted patients. And going back to our previous conversation, I typically for those patients will recommend the EVO ICL. That's often a great bridge procedure because that can fully correct their eyes for great distance vision, and then they use glasses for up close, or it can be done for monovision, and that can often make them free from glasses at all ranges. Let's say, and I only do this maybe a handful of times a year, if that, if someone is very nearsighted, they're for whatever reason not a candidate for the EVO ICL surgery, and they really don't want to keep using glasses and contacts. They're highly motivated for surgery. They understand the risks associated with it. I'll refer these patients to a good retina specialist to get clearance because oftentimes if the retina doctor sees those pre-existing areas of weakness, they can do what's called laser retinopexy in the office to sort of spot weld those areas of weakness into place to make them less likely to develop a tear after refractive lens exchange. And then I typically will have those patients follow up with retina very closely after surgery to make sure their postoperative recovery is smooth. So that's patient selection in terms of eye anatomy. Farsighted patients, almost always great candidates. There are some farsighted patients who have the opposite issue of people who are very nearsighted. Rather than have a very long eyeball, their eyeballs are very short in length, shorter than normal. This is called nanophthalmos, and this may put patients at a risk of different complications compared to the risk of those who have very long eyeballs. So if someone has nanophthalmos, I'm typically recommending against RLE surgery. Again, low levels of nearsightedness, without some of those risk factors we just discussed, they're often great RLE candidates, and high levels of nearsightedness, again, my preference is EVO ICL surgery first. Now, other surgeons may feel differently. They may be more likely to recommend RLE for very short or very long eyes. I always try to remember we're trying to do what's right for the patient. And if there's a higher than average risk of complications for a patient's particular eye with elective eye surgery, I will often recommend against that surgery. Remember, RLE is elective. The patient does not need to have the surgery. Patients who are very nearsighted, eventually they're going to go on to develop a posterior vitreous detachment. And once that happens, the risk of retinal detachment now goes way down. Although typically these patients are now at the age of needing cataract surgery, so the window of RLE has passed, the same surgery, now that they have a cataract, often has far less risk. And patients who are very farsighted, due to the shorter than average eyeball length, unfortunately, they're sort of always at risk for certain complications. It's just that once they finally developed a cataract, the benefits kind of outweigh the risks at that point. So that's patient candidacy in terms of eye anatomy. But again, I alluded to this in terms of expectations and actual results. I think that's almost just as critical. I think it's always important to set expectations, and this is great for making sure patients are happy after surgery. I try to either meet or surpass expectations. So if a patient, let's say, has done well with monovision previously in glasses or contacts, or they're interested in monovision and we try it out in glasses and contacts and they like it, these patients typically are very happy with RLE. And that's because a monofocal lens implant or a toric monofocal lens implant to correct astigmatism, it can replicate that monovision that they've enjoyed before surgery, except now they have that monovision without needing glasses or contacts. But if someone doesn't want monovision and they still want to get out of glasses, to me, that's a much more nuanced decision. And one of the first things I look at, assuming the eye anatomy is normal, is I look at what's that patient's BCVA or best corrected visual acuity. If a patient in glasses in contact lenses can see 20/20 or maybe even 20/15, which is a line better than 20/20, I worry with a multifocal or an extended depth of focus lens implant, they may feel that the quality of their distance vision after surgery is inferior to what it was before surgery when they were in glasses and contacts. We know that patients tend to want their distance vision when it's not corrected after surgery to be very high quality. And if they feel like their vision was better before surgery, they're typically unhappy. Well, why is this? Well, when someone's in their 40s and 50s, there's no cataract yet. They're presbyopic, the lens is stiffened up, their ability to accommodate or pull things in up close, yes, that's diminished, but their lens is still fairly clear and they don't have a cataract. So they can still see fine, they just need the glasses or contacts for that correction. As good as multifocal and extended depth of focus lenses have become in 2025, they work by either putting light on stretch or splitting light into multiple focal points. And as you can imagine, if you're splitting light or if you're stretching light or splitting light, there's an inherent reduction in the amount of light rays or photons getting to a single focal point. And that leads to a slight reduction in contrast sensitivity or quality of vision that patients can perceive with their vision after surgery. So if someone's 2020 or 2015 in glasses before surgery, and we get them to 2020 with surgery, they may feel like that quality of the 2020 vision after surgery is not as good as it was before surgery. And that's because not all of those light rays are going to that single focal point. The lens implant in their eye is now stretching or splitting light. So yes, we may have given them range of vision, but they may be unhappy with their quality of the vision. And they'll always compare what their vision was before surgery to what it is now. And if they don't like it, that's kind of a hard issue to fix without swapping out that lens implant for, let's say, a monofocal lens implant. But that monofocal lens implant, again, will only give them one focal point, and they are now back in glasses for, let's say, near vision or intermediate range of vision. And they usually feel, well, what was the point of having this elective surgery if I'm still in glasses? So if someone can see very well before surgery and they don't like monovision, I typically will not do refractive lens exchange until their vision naturally has dropped to about 2025. You may say, well, okay, 2025, that's not that different than 2020. But at that point, or right around 2025, maybe 2030, the vision they'll get with a multifocal or extended depth of focus lens implant, that 2020 vision they'll get with a lens implant, it will seem better than what their vision was like before surgery. There's more of this delta, so to speak. There's more of a difference in their vision that they can perceive. And that's why cataract patients do really well, all else being regular or equal with their eye anatomy. They do really well with multifocal or extended depth of focus lens implants because that cataract was causing so much blurriness, so many other visual symptoms. Well, once that's gone, the delta is so big, they typically don't perceive some of the trade-offs that are inherent with multifocal or extended depth of focus lenses. So, kind of in summary, in order for me to proceed with refractive lens exchange, the patient obviously has to have good eye anatomy, low risk profile, and again, they have to have the right expectations and a level of preoperative vision that is not quite perfect. Again, other surgeons may feel a little differently, and as lens implants get better and better with their optics, I think we're getting closer and closer to replicating the quality of the vision that the natural lenses we're born with gives, but we're still just not quite there yet.
So once you have selected the right patient, how do you select the right IOL for this procedure? How do you know which one's the right one?
Yeah, this I think just to do at a high level requires just a very deep understanding of the different lens implant options that are out there and the nuances to how each lens implant works. And so we talked about several lens implant classes already. There's something called the monofocal lens. That's just a standard lens implant. It corrects vision for one focal point, so to speak, doesn't correct any astigmatism. Sometimes for patients who want monovision, that's enough. If a patient has astigmatism, which is sort of, their eye being shaped more like a football optically rather than a basketball or a perfect sphere, sometimes they need what's called a toric lens implant, which corrects astigmatism. But lenses like the multifocal lenses, extended depth of focus lenses, we now have monofocal plus lenses. There's a lot of different lens implants that exist. They're made by different manufacturers. Every lens implant works slightly differently. They split light to different focal points. They stretch light to different ranges. And knowing the pros and cons of each lens implant is really important in order to get a patient happy because you have to look at the patient's personality, their occupation, what they like to do for fun in their free time, what their expectations are before surgery, and match that to the right lens implant in order to have a good outcome. It's not a one size fits all. And that's kind of what some of the fun is for me as a surgeon is matchmaking the patient, again, their personality, their lifestyle to the right lens implant. And that just comes from experience, obviously. And then, if you're curious, you'll try all the different lens implants out there and you'll get a sense of what lens implant works best in what situation.
So, what is the diagnostic process like to determine which patients should have this procedure?
Great question. It's pretty much the exact same thing as cataract surgery. So the measurements I get for refractive lens exchange, it's the same workup, same diagnostic testing that I do for cataract surgery. It's just I'm focusing a lot more on what are the risk factors unique to this patient's eye? How good is their vision before surgery? And can I match that or make it even better after surgery? And then, what are their expectations as well?
Okay, so you have determined that the patient is going to have this surgery. What is the time frame like between that determination and then the actual surgery? What's the pre-surgical regimen look like?
Good question. That's pretty individual to each patient. So some patients come in, they've done a ton of research, they've watched videos online, maybe a video like this, let's say, after it goes online. And they're very educated and they know some patients in today's day and age, they know the lens implant sometimes better than some of my other colleagues do. There's so much information for free and online out there. Patients are coming in now very educated. And so if they know the material in advance, the consult is almost more of, okay, am I a candidate for this procedure? Am I a good candidate for this procedure? And can you make me happy with this procedure? And a patient who's highly motivated, sometimes from consult to surgery, it can be as quick as a week. I saw a patient just yesterday on Monday, or 2 days ago on Monday, who I'm going to be operating on later this week on Friday because they're just very motivated. They know what the pros and cons are. We sat down and went through all of that, and they're just at a point in life where they just want to get it done. Some patients are a little different. They need some time to think on things. They need to weigh the pros and cons, maybe talk to family members, friends, do some more research online. And so I always tell patients for an elective surgery, there's no rush. It doesn't have to be done. It's always fine to continue in glasses and contacts if you'd like. And as you do your own research, if you want to discuss things more, again, I'm happy to sit down in person or discuss things over the phone. So the timeline to surgery from consultation is just different to each patient. Some patients, they want surgery within days, and some patients, they'll come back in 2 or 3 years and finally they're ready at that time.
So, how does the procedure work?
Great question. So the procedure again is identical to cataract surgery. There's some nuances in terms of removing the lens before it's become a cataract compared to when you're removing a cataract. Just the density of the lens is different, the way it handles in the eye, the sort of the fluidics are a little bit different, but the procedure in terms of overall steps is the exact same. So a patient is brought into the operating room. There's an anesthesia team in the room at all times, so they're comfortable, they're a little sedated, their eye is numb. We give plenty of numbing medicine. And then we make two micro incisions on the edges of the cornea, and we insert our instruments through that, gently manipulate the lens to get it out of its support structure, and then using ultrasonic energy in a micro vacuum, remove the pieces of that lens. We leave the support structure of that lens intact because that is what is going to house the new lens implant. So the new lens implant, when it goes in the eye, it's scrolled or folded up and it goes through those micro incisions and then gently unfolds within the patient's eye. And then after that, once the lens implant's in place, if it's a toric lens implant, it needs to be lined up to a specific axis to correct for a patient's astigmatism. I obviously do that. And then it's just simply a matter of removing the gentle substances introduced into the eye to safely do the surgery. After that, patients go home the same day. The dilation that we use typically wears off within 24 hours or so. And at that point, patients are already seeing quite well. We usually have them on a combination eye drop that contains a steroid, an antibiotic, and an NSAID component. The antibiotic is obviously to make sure the patients don't develop any infections after surgery. The steroid is to help with quelling the natural inflammation that comes from surgery. And then the NSAID component is to prevent any swelling that is sometimes a risk for patients with a retina. And patients are typically on that for about a month or so. Every surgeon has their own different protocol in terms of what antibiotic they use, what steroid they use. Some people have patients on the drops 4 times a day. Some people have it on it twice a day, sometimes once a day. But for all intents and purposes, those three components are typical to refractive lens exchange, and most of the healing takes place within that first week.
So, tell me a little bit more about the recovery process for RLE. What exactly is the recovery time frame? What's that process like?
Yeah, great question. So again, I always tell patients the first 24 to 48 hours, they may feel a little itchiness, some grittiness, some scratchiness on their eyes, and that's normal. The more naps they take, the more they sleep, or they use some artificial tears, that's typically gone within the first couple days after surgery. After that, they may be much more light sensitive. All of a sudden now that natural lens has been removed from the eye and a lot of light is now getting into the eye. Especially while they're still dilated after surgery, I often recommend wearing a pair of sunglasses. After about 24 to 36 hours, that dilation's worn off. People may still be a little bit more light sensitive, but that often will go away within the first several weeks after surgery. If a patient is just having a monofocal lens implant, let's say we're going for monovision, or we're just aiming for distance vision, or just near vision, the recovery is usually very quick. After, I mean, within the first day or two, they're really seeing great already. The same is also true for patients who have a multifocal or maybe an extended depth of focus lens, but sometimes some of those side effects that come with those lenses can be a little bit more prominent immediately after surgery. So what do I mean by that? Well, most multifocal lenses work because they have concentric rings built into the middle of the lens. And those rings are what split light to those different focal points, and that's what gives patients glasses-free range of vision. It gives patients the ability to see everything without the need for glasses. Well, a side effect of that is around light sources, especially at night, like oncoming headlights. Those rings can lead to the appearance of some glare or halos around lights. And that tends to be most prominent for patients if they're going to notice it, usually in those first several weeks after surgery. And sometimes it takes several months for patients' brains to neuroadapt for that. So the the immediate, let's say, physical recovery from the surgery, that's usually very quick. Most of the healing is done within the first week. Certainly by the first month after surgery, the eyes are fairly healed and stable. And then sometimes it's then up to the brain to neuroadapt, and that can take several more weeks or months, depending on what lens implant was used.
Well, is there anything else you would like to tell our audience today? I mean, that was a lot of really wonderful information.
Yeah, well, I appreciate the time as always to discuss. I think, refractive lens exchange is becoming more and more popular, and I think that's directly tied to the quality of vision that modern lens implants can give. So, in the past, let's say 10 years or so, we've seen tremendous improvements in optics in terms of the quality of vision that multifocal lenses or extended depth of focus lenses can give. And obviously, every year, surgical instruments, surgical techniques, everything, as is the nature of technology, just keeps improving. And so I think patients, if they want to have their vision corrected with a refractive lens exchange, and if they're a good candidate with low risk factors, I think, there's never really been a better time in history to get independence from glasses and contacts at an earlier point in life. It's just important, again, to, I think, see a surgeon who's familiar with all the different lens options, who's familiar with all the different procedures, because maybe you're someone who's better for EVO ICL than RLE, let's say. And it's important to see someone who's ethical and honest and is not afraid to tell you no. And I often tell patients, if I tell them no, they're not happy with me because they really wanted surgery. I view it as my duty to educate them about the risks. And I know some patients are going to go see other surgeons who maybe will say yes. And, I don't know what ends up happening to those patients. Hopefully they have good outcomes and they're happy with their vision. But I think it's important for the surgeon to just do right by the patient and don't do something you're not comfortable doing. And I think if patients can select for surgeons like that who will be honest and truthful with them, then they'll have a good outcome, whether that's continuing glasses and contacts and waiting until cataract surgery, or maybe having refractive lens exchange and seeing great right now.
Well, thank you very much, Doctor. Thank you for joining us today.
Of course. Thanks so much. As always, appreciate it. Bye-bye.